Welcome to PRISM Rounds, the audio journal club for busy clinicians who want the bottom line, the nuance, and the bedside relevance of new medical evidence. In this episode, we're looking at a deceptively simple airway question. When we choose Rocuronium for emergency intubation, are we giving enough of it? A new secondary analysis of the DEVICE and PREOXI trials found that doses above 1.2 milligrams per kilogram were associated with higher first-attempt intubation success, with the strongest signal in ICU patients. We'll break down the study, the accompanying editorial, and what these findings should and should not change at the bedside. If you find PRISM Rounds useful, subscribe on Apple Podcasts, Spotify, or YouTube, and share the podcast with a colleague.
Picture this. You're standing in a really cramped room in the ICU at 2 in the morning.
Right. The classic scenario.
Yeah, exactly. The monitors are just glaring, right? Casting this harsh blue light across the bed. And the alarms are sounding.
Oh, that relentless, high-pitched rhythm.
It sets your teeth on edge. And your patient is critically ill. I mean, they are failing fast.
Oxygen saturations are just dropping precipitously.
Right. From 92 to 88 to 83.
And the respiratory therapist is right there at the head of the bed.
Yeah, they're bagging, just trying to force oxygen into these lungs that are stiff, diseased, and failing.
It's incredibly tense.
The whole team is gathered, and you can just feel the tension radiating off everyone in the room.
Absolutely.
So you're drawing up your induction agents, you have your video laryngoscope ready, the screen is glowing brightly, and, well, you reach for the paralytic.
The team chooses Rocuronium.
Exactly. You draw it up. You calculate the dose in your head based on the patient's weight, and you push it into the line.
Right into the IV.
But in that crucial high-stakes moment, a question kind of just hangs in the air. We obsess over the paralytic. Are we giving enough of it?
Man, I mean, it really is the ultimate question in that agonizing 2-minute window.
It feels like an eternity.
It does, because you are about to take away a human being's ability to breathe,
Right.
to protect their own airway.
To live, basically.
Right, to live without your direct, immediate intervention. Airway management in the critically ill is entirely binary.
You get the tube in or you don't.
Exactly. And the consequences of not getting it in on that very first attempt, they're just catastrophic.
Welcome to this deep dive. Today, we are taking a really deep dive into the clinical literature, and we're unpacking a fascinating piece of research that gets right to the heart of that terrifying ICU scenario I just described.
It's such an important topic.
It really is. So welcome to PRISM Rounds, Season 1, Episode 54.
Glad to be here for this one.
We're looking at a study by April and colleagues. It was published in the American Journal of Respiratory and Critical Care Medicine.
And there's a fantastic accompanying editorial, right?
Yeah, a brilliant editorial titled Dose Matters, Rocuronium and First Pass Intubation Success.
And, this literature is incredibly relevant for you, whether you're the one actually holding the laryngoscope or drawing up the medications or even managing the patient post-intubation.
Because we are talking specifically about the critically ill.
Right. These are patients who have what we call a physiologically difficult airway.
They just don't have the reserve of a healthy patient.
Not at all. It's not like an elective surgery in the controlled environment of the operating room.
Not even close.
If you miss on the first attempt with these critically ill patients, you are immediately exposing them to severe immediate risks.
Like profound hypoxemia.
Exactly. Cardiovascular collapse and even cardiac arrest.
So our mission for this deep dive is to figure out if what we've all been taught, the conventional ceiling dose of Rocuronium, might actually just be a floor for critically ill patients.
Right.
But we need to start with the why. Like, why does the exact milligram per kilogram dose of this specific drug matter so much in this specific moment?
Well, to understand the why, we really have to go down to the microscopic level.
Down to the cellular level.
Right down to the neuromuscular junction.
Okay, let's get into the pharmacology.
So Rocuronium is a non-depolarizing neuromuscular blocking agent.
A paralytic.
Yes. And its job, once it enters the venous system, is to travel through the bloodstream, reach the neuromuscular junction, and essentially block the nicotinic acetylcholine receptors.
Right at the motor end plate.
Exactly. It competes directly with acetylcholine, and when it successfully occupies those receptors, the muscle just cannot contract.
It becomes completely flaccid.
Which is exactly what you want when you're trying to pass a rigid plastic tube through the vocal cords.
Right, you want the jaw completely relaxed.
The upper airway soft and compliant, and the vocal cords completely perfectly still.
And the FDA label tells us exactly how to achieve this. The standard dosing instructions for rocuronium advise giving anywhere from 0.6 to 1.2 milligrams per kilogram.
That's the classic window.
That's what we learn in our training. You calculate the patient's weight, you stay comfortably in that defined window, you push the drug, and you just wait for the magic to happen.
Right, but the speed of that magic happening is entirely dependent on pharmacokinetics and some really complex physiological variables.
Okay, break that down for us.
The speed of onset, so how fast those vocal cords actually stop moving, depends on two main things.
Okay.
First, it depends on the time it takes for the drug to physically travel from the intravenous site, move through the right heart, into the pulmonary circulation, out the left heart, and distribute to the effect site.
Which is the skeletal muscle bed.
Precisely. And second, and this is really crucial, it depends on the concentration gradient of the drug at that specific neuromuscular junction once it finally arrives.
Wait, hold on though. There's a massive fundamental difference between a controlled intubation in the operating room and an emergency ICU intubation.
Oh, absolutely. Night and day.
Right. Because in the operating room, the patient is almost always hemodynamically stable.
They have a totally normal cardiac output.
But in the ICU, everything is just absolute chaos, biologically speaking.
That is the defining distinction, and honestly, it's the entire biological premise behind why dosing might need to change.
Because the physiology is totally deranged.
Exactly. In a critically ill patient, you're dealing with severely altered, deranged hemodynamics.
So think about a patient in severe cardiogenic shock.
Right. They might have a terrible cardiac output because their left ventricle is just failing.
The pump is broken.
The pump is broken, so the drug simply takes longer to circulate.
Or what about a patient in profound distributive shock, like severe sepsis?
That's even trickier because their blood vessels are massively dilated, their systemic vascular resistance has plummeted, and the body, in this desperate bid for survival, is actively trying to shunt whatever effective blood flow it has away from the non-essential skeletal muscles.
Right, redirecting it toward the vital organs.
Exactly. The brain, the heart, the kidneys.
So if the body is actively, aggressively diverting blood away from the skeletal muscles, your paralytic is basically taking the scenic route.
Pretty much, yeah.
It's getting stuck in traffic. It's moving sluggishly through a microcirculation that is barely even perfused.
Exactly. The shock state slows down drug delivery to the effect site significantly. You push the syringe, but the molecules are just crawling toward their destination.
Wow.
And this is exactly where that second factor we mentioned, the concentration gradient, becomes absolutely vital.
Because you need a certain amount of drug at the junction.
Right. If you increase the administered dose of rocuronium, you're drastically increasing the sheer number of molecules floating around in whatever small fraction of blood is actually reaching those muscles.
You fundamentally alter the concentration gradient.
Yes. You are potentially forcing a faster, deeper, and more consistent paralysis simply by overwhelming the system with volume.
It's kind of like, think of the neuromuscular junction like a crowded toll booth on a multi-lane highway.
I like that analogy.
Right. You need a certain number of cars, which represent the rocuronium molecules, to get through the gates to successfully shut down the highway and stop traffic.
Makes sense.
If you send a slow, steady, trickling stream of cars, it takes quite a while for them to fill up all the toll booths and block the lanes.
Right, because they're just trickling in.
But if you send a massive, overwhelming fleet of cars all at the exact same time, they swamp the gates immediately.
They jam it up instantly.
Exactly. By giving a higher dose, you're sending that massive fleet. You're overwhelming the nicotinic receptors faster than you ever could with a smaller dose.
That is a perfect way to visualize the kinetics of competitive antagonism at the receptor level.
Thank you.
By increasing the sheer volume of rocuronium molecules, you overcome that sluggish, impaired delivery system of a critically ill patient.
You essentially force the issue at the receptor site.
Exactly. And that theoretical physiological benefit, the idea that more molecules equals faster, better intubating conditions in sick patients, is what brings us to the clinical data.
Which is what April and colleagues were looking at.
Right. They wanted to see if that massive fleet of cars actually translates to measurably better outcomes at the bedside where it truly counts.
Let's dive deep into how they actually try to answer that question, because the methodology here is complex.
It's very complex.
First and foremost, we have to establish clearly what this study is, and just as importantly, what it isn't.
I cannot stress this enough because it frames everything we're about to discuss. This is not a randomized controlled trial of rocuronium dose.
The investigators did not randomize critically ill patients to receive a high dose versus a low dose of paralytic.
Right. It is a secondary observational analysis.
Okay, so where did the data come from?
They took data from 1,822 adult patients who were already enrolled in two separate, massive, multi-center randomized controlled trials conducted in emergency departments and intensive care units.
Ah, okay. The DEVICE and PREOXI trials.
Yes. One was the DEVICE trial, which compared the use of a video laryngoscope versus a direct laryngoscope for intubation.
And the other?
The other was the PREOXI trial, which looked at strategies for pre-oxygenation prior to intubation, specifically comparing a standard face mask to non-invasive positive pressure ventilation.
Got it. And because these were high-quality prospective randomized trials focused specifically on airway management, the research coordinators and data collectors were already meticulously, obsessively recording every single detail of the intubations as they happened.
Exactly. They were recording the exact drugs, the exact doses, the timing, the equipment, the operator experience, the oxygen saturations minute by minute.
So it gave April and colleagues an incredibly rich, granular data set to look at retrospectively.
It really did. They took all the patients who received Rocuronium as their primary paralytic across both of these trials, pooled them together, and then split them into two distinct exposure groups based on the dose the clinician happened to choose.
And the dividing line they chose was the absolute top end of the FDA label.
Right, that 1.2 mark.
The high-dose group was defined as anyone who received greater than 1.2 milligrams per kilogram of actual body weight.
And that cohort consisted of 720 patients.
Okay. And the standard dose group was defined as anyone who received 1.2 milligrams per kilogram or less.
Which was a larger cohort with 1,102 patients.
And their primary outcome, the main clinical endpoint they were looking for, was successful tracheal intubation on the first attempt.
Right. Did the endotracheal tube successfully pass through the vocal cords on the very first try without needing to withdraw the blade and start over?
Now, because this is not a randomized trial, because the doctor standing at the bedside chose the dose in the heat of the moment based on their own judgment, the researchers had to do some incredibly complex statistical gymnastics.
They absolutely did, to make sure they were comparing apples to apples.
And we really need to get into the weeds of the methodology here, because the stats matter immensely when interpreting observational data.
They really do. When you let clinicians choose the dose of a drug, you immediately introduce selection bias and confounding.
Because, maybe they give higher doses to younger, more robust patients.
Exactly. Or maybe they give lower doses to older, frailer patients. So to attempt to level this playing field statistically, the researchers utilized some very robust techniques.
Like propensity matching.
Yes. Think of propensity matching as a way of creating synthetic twins within the data set.
Okay, how does that work?
If you have a 65-year-old male with severe sepsis who happens to have been given the high dose of Rocuronium, the algorithm searches through the standard dose group to find a patient who is as close to identical as mathematically possible.
So someone with the same age, same illness severity.
Same underlying pathology, even intubated by an operator with the same level of experience just to compare them against?
That's clever. And they also use multiple imputation for missing data, right?
They did. In clinical research, especially in emergency settings, data is always missing.
Oh, yeah. A weight isn't recorded. A specific blood pressure reading is missed in the chaos.
Right. So multiple imputation is this sophisticated statistical modeling technique that fills in those blanks based on the patterns in the rest of the data.
It creates multiple complete data sets to analyze.
Exactly. So you don't skew the results by just throwing out every patient who happens to have one missing variable.
Which would ruin your sample size.
Yep. They also use covariate adjustment for a whole host of patient and operator characteristics, age, sex, body mass index, operator experience.
And site modeling.
Yes, treating the specific hospital site as a random effect, because we know the intrinsic culture of care, like the default practices at Hospital A, can be completely different than the default practices at Hospital B.
Right, but no matter how complex your propensity matching is, you cannot statistically adjust for the eyeball test.
The eyeball test is so real.
It is. You walk into a room, you look at a patient in the bed, and your clinical intuition just screams, this airway is going to be an absolute disaster.
Right.
The electronic medical record might say they have the exact same heart rate, the same blood pressure, the same oxygen saturation as the patient next door, but they just look different.
They're diaphoretic, they're agitated, their anatomy looks hostile.
Exactly. And that subjective, unrecorded gut feeling absolutely influences how a doctor doses a drug in the moment. You can't put that in a spreadsheet.
You are 100% correct. That is the very concept of unmeasured or residual confounding.
And the editorial authors highlight this exact limitation beautifully.
They do, because no matter how good the math is, no matter how many covariates you adjust for, this remains an observational snapshot of clinical behavior.
Right.
And if we look at the raw baseline characteristics of the patients in this study, before all the statistical adjustments, we actually see some very important telling imbalances that prove your exact point about clinical intuition.
Oh, really? Like what?
Well, the standard dose group, the ones who received 1.2 milligrams per kilogram or less, actually had a higher median body mass index. They had a higher incidence of sepsis or septic shock, nearly 46% of them compared to about 37% in the high-dose group.
So they were sicker.
And crucially, they had a slightly higher documented likelihood of having an anticipated difficult intubation based on the clinician's assessment prior to the procedure.
That is endlessly fascinating. So the clinician standing at the bedside were looking at these heavier, sicker, potentially more anatomically difficult patients, and they were consciously choosing to give less paralytic per kilogram.
Yes.
Maybe out of a deep-seated fear of causing cardiovascular collapse in a fragile patient, or maybe just out of ingrained habit.
It could be either or both.
But it proves definitively that these two groups were not perfectly identical from the start. The clinicians were treating them differently based on how they presented.
Exactly. The complex statistical models try their best to smooth out those imbalances and isolate the effect of the drug dose itself, but we have to maintain a healthy skepticism.
We have to keep that reality of clinical bias in the back of our minds as we interpret the final results.
Definitely.
So keeping in mind that we are looking at an observational snapshot of a very messy, dynamic clinical reality, let's look at the headline results.
The numbers.
Right. Did the massive fleet of cars, the higher dose of Rocuronium, actually make a difference in getting the tube in on the first try?
Well, the absolute numbers are quite striking right out of the gate.
Okay, let's hear it.
Successful first attempt intubation occurred in 89% of the patients in the high dose group,
89%.
compared to 81.6% in the standard dose group.
Wow. That is a massive gap in the critical care world. I mean, an almost 8% difference in raw success rates for a life-saving procedure is huge.
It really is.
But let's break down what that actually means statistically after they ran all their propensity matching and covariate adjustments to try and balance out those baseline differences we just discussed.
Sure. So after robust adjustment, the relative risk was calculated at 1.07.
With a 95% confidence interval spanning from 1.02 to 1.12.
Right. So what we're looking at is a statistically significant increase in the probability of success when the higher dose was used.
And when you translate that into absolute terms,
The absolute risk difference was about 5.5 percentage points.
a 5.5 percentage point absolute increase in success.
Exactly.
And that gives us the metric I always care about most at the bedside when evaluating a new intervention. The number needed to treat.
It's the most practical metric.
It really is. And it was about 18. This means for every 18 critically ill patients you give the higher dose of Rocuronium to, you get one additional successful first attempt intubation that you would have otherwise missed if you'd used the standard dose.
Which is significant.
An absolute number needed to treat of about 18 in the high-stakes realm of airway management is something we absolutely have to pay attention to.
It definitely commands attention. But as a data analyst and a clinician, when I see an intervention that involves giving a significantly higher dose of a very powerful pharmacological agent, my immediate instinct is to look for the trade-off.
Right. What's the catch?
Exactly. What is the physiological cost of that higher dose?
And that is the natural, obligatory clinical question you just have to ask. If we give more paralytic, are we inadvertently causing more harm?
Because we know these drugs and the process of intubation itself have profound physiological effects on the body beyond just freezing the skeletal muscles.
The researchers were acutely aware of this, right?
They were, and they looked very closely at the safety profile, specifically focusing their attention on the critical 2-minute window immediately following the intubation attempt.
Which is the physiological danger zone.
Exactly. This is when the most severe immediate complications tend to manifest, and the results regarding safety were quite reassuring.
That's good to hear.
Their adjusted analyses showed no significant increase in the incidence of severe hypoxemia, which they rigorously defined as an oxygen saturation dropping below 80%.
No increase there.
No. There was no increase in severe hypotension, defined as a systolic blood pressure plummeting below 65 millimeters of mercury.
Okay.
There was no increase in the need for new or escalated vasopressor support to maintain perfusion, and most importantly, there was no increase in peri-intubation cardiac arrest.
So we have a higher first attempt success rate, and at least in that immediate, terrifying peri-intubation window, there is no obvious spike in catastrophic cardiovascular or respiratory harm.
It's a very compelling combination.
It really is. And they also looked at the time to event curve, correct? They looked at how fast things actually happen.
They did, and the time to event analysis lines up perfectly with the underlying pharmacokinetic theory and our toll booth analogy.
Oh, how so?
Higher doses of rocuronium were associated with a significantly shorter time from the exact moment the induction drugs were administered to the moment the endotracheal tube was successfully placed.
So the neuromuscular blockade happened faster.
The intubating conditions were optimized quicker, and the tube went in sooner.
Okay, a faster, more successful intubation with no obvious spike in immediate complications. That sounds like a fairly clean sweep for the higher dose. But here's where it gets really interesting.
Because it's never that simple, is it?
Never. When you split this data apart and look at where these intubations were actually happening, the story completely diverges.
It really does. It's one of the most fascinating aspects of the study. The researchers stratified their outcome data based on the physical location of the intubation within the hospital.
Specifically, the intensive care unit versus the emergency department.
And the results in those two distinct environments were completely different.
Let's lay out the precise numbers for this ICU versus ED paradox, because it is central to understanding how to apply this data.
Absolutely.
Yeah.
So in the ICU, the signal for benefit from high-dose rocuronium was incredibly strong.
Give us the stats.
The adjusted relative risk for first attempt success was 1.13.
Okay.
The absolute difference in success rates was a massive 10.3 percentage points.
Wow.
And the number needed to treat dropped all the way down to about 10.
Wait, so for every 10 patients you intubate in the ICU, utilizing the higher dose saves one patient from a failed first attempt and all the potential complications that follow.
Yes.
That is an enormous effect size for a simple dosing change.
But then you turn your attention to the emergency department cohort.
Right, the ED.
In the ED, there was no clear association at all between the higher dose and improved success. The adjusted relative risk was B0.97.
It was basically a wash.
Exactly. This represents a statistically significant interaction.
Aiming.
The drug literally appeared to work differently, or at least have a different impact on the final outcome, depending entirely on which floor of the hospital the patient was physically located on.
Wait, hold on. A non-depolarizing neuromuscular blocker does not know if the patient's bed is in the basement, in the ED, or up on the 4th floor in the medical ICU.
Obviously not.
So why would geography change the drug's fundamental efficacy?
That is the million-dollar question, and it's where we have to step away from the hard numbers and engage in some educated clinical speculation.
Because the data only tells us what happened, it doesn't definitively tell us why.
Right. We have to think deeply about the different patient phenotypes that populate those two environments.
Okay, let's contrast them.
In the emergency department, you are seeing a much higher volume of trauma patients.
Sure.
A trauma patient who is perfectly healthy an hour ago, who has a pristine airway and normal baseline physiology before their accident, has a very different physiological reserve than a complex medical patient.
Right, someone who has been languishing with severe bilateral pneumonia for 5 days and is now slowly failing on a ventilator in the ICU.
Exactly. It makes profound biological sense. A trauma patient might be actively bleeding, they might be in hemorrhagic shock, but their skeletal muscles aren't necessarily bathed in days' worth of inflammatory cytokines, systemic edema, and metabolic derangement, like a patient with progressive ICU sepsis.
That's a great point. The underlying milieu is different.
Furthermore, consider a trauma patient presenting to the ED with a severe traumatic brain injury or a high spinal cord injury.
Oh, right.
They might already have significantly reduced pre-intubation muscle tone simply due to their neurological insult.
Compared to a combative, hypoxic, delirious medical patient fighting the breathing mask in the ICU.
Yes. You simply might not need as much paralytic to achieve favorable, relaxed intubating conditions in that specific trauma scenario.
What about the actual intubation practices themselves? You know, the operational culture of the ED versus the operational culture of the ICU.
This is a huge, often underappreciated factor in multi-center trials. The study explicitly noted that emergency department sites generally generally utilize significantly higher weight-based dosing overall as their default practice, compared to the ICU sites.
Wait, so ED physicians were already inherently giving higher doses on average before the study even categorized them?
Yes, ED culture often emphasizes very rapid, very aggressive pharmacological control of the airway.
That makes sense. They deal with a lot of chaos.
They're accustomed to chaotic presentations and might be more inclined to grab larger doses of paralytic by default to ensure immediate paralysis.
So how does that skew the data?
If the ED as a whole is already heavily skewing toward higher doses, it becomes mathematically much harder to detect a distinct difference in outcomes between the high-dose and standard dose groups.
Because the standard group in the ED might still be receiving a relatively robust, effective dose.
Exactly, especially compared to the truly lower doses being used in the ICU standard group.
That is a brilliant point about the baseline practices skewing the comparison. And we also have to consider the human element, the operators themselves.
Right, who is actually intubating?
In a large academic teaching hospital, the person actually holding the laryngoscope in the ED might be an emergency medicine resident.
Whereas in the ICU, it might be a critical care fellow, an anesthesia resident, or an attending pulmonologist.
And their varied training levels, their preferred techniques, how they position the patient.
And critically, how long they patiently wait between pushing the paralytic and actually grabbing the laryngoscope blade.
Yes. All of these unmeasured, highly variable human factors differ significantly between those two unique clinical environments.
It highlights just how unbelievably complex clinical research is when you bring it to the bedside.
You're never just testing a drug in a vacuum.
No, you're testing a drug within a specific, highly nuanced ecosystem of care. And the ICU ecosystem, with its specific patient phenotypes and specific default dosing cultures, seems to be the place where this specific intervention...
Deliberately cranking up the rocuronium dose.
Right, where it has the most profound, measurable impact on success.
Speaking of the ecosystem of care and how things actually happen in real life, the editorial that accompanies this study really zeroes in on the bedside reality.
It brings an incredible, refreshing pragmatism to this whole statistical discussion.
It really does. The editorialists essentially pause the high-level debate about relative risks and propensity scores and ask a very basic practical question about human behavior.
Which is, how do we actually dose medications in the middle of a terrifying emergency?
And they highlight a fascinating clinical reality that they call the 100 milligram vial phenomenon.
This is perhaps the most relatable part of the entire deep dive.
Because it is so incredibly true to practice. I mean, think about the massive cognitive load of an emergency intubation.
It's overwhelming.
You're trying to mentally manage the airway anatomy, you're watching the oxygen saturation monitor plummet, directing the respiratory therapist.
And communicating clearly with the nurse who's drawing up the medications under extreme pressure.
Right. You look up and say, give the rocuronium. In a vast majority of institutions across the country, rocuronium comes stocked in a standard 100 milligram vial.
And what the raw data in the study revealed was just startling.
What did it show?
The median absolute dose of rocuronium administered in both the high-dose group and the standard dose group was exactly 100 milligrams.
The exact same absolute dose, right down to the milligram, in both groups.
Yep.
So what is actually happening at the bedside here?
What's happening is that many clinicians, when faced with a crashing patient, aren't doing strict, precise, weight-based math in their heads.
No, of course not.
They aren't looking at the bed and saying, okay, this patient weighs precisely 83 kilograms. I want exactly 1.2 milligrams per kilogram, so nurse, please draw up exactly 99.6 milligrams.
Right, nobody says that. They're looking at the chaos and saying, just give the whole vial.
They just hand over the standard 100 milligram vial and say, push it all right now. It is cognitive offloading.
Exactly. It's a simplification strategy in a crisis.
And because of that widespread behavioral reality, the dose categories in this study, that artificial line drawn at greater than or less than 1.2 milligrams per kilogram, might actually just be functioning as a complex proxy for patient weight.
Okay, walk us through that math.
If I give a standard 100 milligram vial to a small 60 kilogram patient, they are receiving roughly 1.6 milligrams per kilogram.
So they automatically land in the high dose group.
Right, but if I give that exact same 100 milligram vial to a larger 100 kilogram patient, they are receiving exactly 1.0 milligrams per kilogram.
And they automatically land in the standard dose group.
Precisely.
So the study's finding that high weight-based dosing is associated with better outcomes might partially just be telling us that Standard fixed 100 milligram dosing works really well for lighter people, but it potentially systematically underdoses heavier people.
It is a very distinct biologically plausible possibility. It strongly suggests that our deeply ingrained bedside practice of fixed-dose, vial-based administration driven by convenience and cognitive load is fundamentally influencing the very data we're trying to analyze.
Wow. If we're just throwing a fixed 100 milligrams at everyone, the people who really get skewed by that practice are the extremes of body habitus.
Yes, absolutely.
Let's look at the data on obesity, because heavier patients present unique physiological challenges for drug dosing.
The study did perform a subgroup analysis and showed that high-dose rocuronium provided a clear benefit in patients with obesity, improving their first-attempt success rates.
However, the editorial authors bring up a really crucial cautionary nuance here regarding how we actually calculate weight for these specific drugs.
Right, because the strict FDA label instructs us to use actual body weight when calculating the dose for rocuronium.
But anybody who works in a critical care setting knows that dosing hydrophilic drugs, drugs that love water, that stay primarily in the blood and the extracellular fluid.
And do not distribute extensively into adipose or fat tissue.
Right. Dosing those based strictly on actual body weight in a severely obese patient can lead to massive, unintentional overdoses.
Precisely. Rocuronium is a highly hydrophilic molecule. It largely stays confined to the extracellular fluid compartment.
So giving it based on total body weight is risky.
The editorial meticulously notes that in elective surgical patients with obesity, dosing rocuronium based on ideal body weight, or perhaps an adjusted body weight formula, actually seems to provide very similar onset times.
And perfectly adequate intubating conditions compared to actual body weight dosing.
But critically, without the massive drawback of profoundly prolonging the duration of the paralysis.
Okay, so if you have a patient weighing 150 kilograms and you rigidly follow the actual body weight rule, and decide to give them a high dose of 1.5 milligrams per kilogram.
You are pushing over 220 milligrams of rocuronium.
That is a massive dose. It might get you a good, relaxed intubating condition quickly, but they are going to remain chemically paralyzed for a very, very long time.
Which we will talk about the intense dangers of in just a moment.
Right. But first, let's shift to another subgroup analysis that I found mechanically fascinating.
Yeah.
The data surrounding the use of a bougie.
Oh, this was a great part of the paper.
We know a bougie gives us a massive mechanical advantage during difficult intubations because of its tiny maneuverable profile compared to a standard endotracheal tube.
So how did the high-dose rocuronium strategy interact with bougie use?
The researchers found something very interesting here. There was absolutely no difference in first-attempt intubation success between the high-dose and standard-dose rocuronium groups when a bougie was utilized as part of the intubation strategy.
The statistical benefit of the higher dose completely vanished in this specific subgroup.
You know, this makes perfect sense to me if you just visualize the raw mechanics of the procedure. If you're trying to shove a relatively thick, rigid, blunt-ended endotracheal tube directly through the vocal cords, you need those cords and the surrounding musculature to be completely perfectly flaccid.
Because any slight movement, any residual muscle tone, any spasm.
And that thick tube is going to bounce right off the cords, and your attempt fails.
But if you are initially just trying to guide a thin, flexible, highly maneuverable bougie through that same glottic opening, you have a much smaller, more forgiving profile.
Exactly. You might not need the airway muscles to be as profoundly, maximally paralyzed to successfully slip that thin guide wire through the opening.
The physical adjunct device, the bougie, essentially overcomes the physiological need for absolute maximum pharmacological muscle relaxation.
That is a brilliant demonstration of how physical tools alter physiological requirements. What about videolaryngoscopy?
Right, because we are using cameras on the end of our blades almost universally now.
Did the dose matter when the operator had a screen?
The subgroup analysis did show a continued benefit for high-dose rocuronium when a videolaryngoscope was used.
Okay.
However, both the original study authors and the editorialists issue a very strong warning against overinterpreting this specific finding.
Why is that? Why should we be cautious about that data point?
Because we have to remember the origin of this data.
Yeah.
This was a secondary analysis pooling data that included the DEVICE trial. And the DEVICE trial fundamentally proved that videolaryngoscopy, as an intervention itself, significantly improves first attempt success over direct laryngoscopy.
So the interactions in this retrospective data are incredibly tangled and complex.
Was the improved success in this subgroup due to the superior view from the camera, the physiological effect of the high dose of rocuronium, or the specific unmeasured characteristics of the patient that prompted the operator to choose a camera in the first place?
We simply do not have the statistical power or the randomized design in these small subgroups to make a definitive causal claim.
No, we don't.
But this is where we really need to pause and be careful. We spent a lot of time talking about the potential benefits of this massive fleet of cars, the faster onset, the overwhelming of the toll booths, the improved success rates in the ICU.
We have to pivot now and talk about the clinical caveats.
Because the editorial rings a very loud, very necessary warning bell about the realities of high-dose paralytics.
The loudest warning bell they ring is a reminder of the fundamental nature of the evidence. These findings are hypothesis-generating.
They are not definitive proof of causality.
We absolutely cannot change global clinical guidelines or institutional protocols based solely on a secondary observational analysis, no matter how clever the propensity matching or the multiple imputation models are.
The editorial points out the major, undeniable pharmacological drawback of high-dose rocuronium, which we touched on briefly with the obesity discussion. The paralysis simply lasts significantly longer.
It is basic pharmacokinetics. If you give a massive, overwhelming dose of a drug, you have massively increased the total body burden of that molecule.
It inherently takes the body's organs, the liver and the kidneys, longer to clear it from the plasma.
And it takes longer for the nicotinic receptors to eventually recover their function. And in the environment of the ICU, prolonged, unyielding paralysis is not a benign, harmless condition.
It is a massive clinical problem. Think about the workflow. If a patient comes into the ICU with an altered mental status of unknown etiology,
or perhaps they suffered a brief cardiac arrest before their airway was secured,
the very first thing the neurologist or the intensivist wants to do, the second that endotracheal tube is confirmed, is perform a reliable neurological assessment.
Are they moving their arms and legs?
Do they have intact pupillary and corneal reflexes? Are they beginning to follow simple commands?
If you aggressively hit them with 1.5 or 2.0 milligrams per kilogram of rocuronium to secure the airway, you might completely wipe out their motor function for hours.
You have entirely delayed that crucial, time-sensitive, early neurologic assessment.
You functionally blind yourself to their true brain function during a critical window of care.
And most importantly, and this is a topic that should frankly keep every single critical care clinician awake at night, we have to talk about the absolute necessity of post-intubation sedation.
The nightmare scenario of awake paralysis.
Exactly. When we perform a rapid sequence intubation, we give a fast-acting induction agent to put the patient to sleep and render them amnestic.
Drugs like etomidate, ketamine, or propofol.
Right. And simultaneously, we give the paralytic. But the critical flaw is that those induction agents are designed to be short-acting.
They redistribute quickly and often wear off in maybe 10 to 15 minutes.
But if you gave a high dose of rocuronium, the dense muscle paralysis is going to last for an hour, maybe considerably more depending on their organ function.
If the clinical team is not hypervigilant, if your nurse does not have a propofol drip or a fentanyl drip already mixed, ready to go, and running the very second that endotracheal tube is secured with tape,
that patient is going to wake up.
The induction agent wears off, and their brain turns back on. They will regain full consciousness.
But because of the massive dose of rocuronium still occupying all their receptors, they will be entirely trapped in a body that cannot move a single millimeter.
They will have a rigid plastic tube shoved down their trachea, they will be unable to take a breath on their own, and they will be lying there awake and terrified, just waiting for the mechanical ventilator to force air into their lungs.
It is unimaginably, profoundly traumatic.
The documented incidence of severe post-traumatic stress disorder in ICU survivors who experience episodes of awake paralysis is horrific.
It's just awful. The editorial forcefully stresses that if you are going to entertain the idea of utilizing higher doses of rocuronium to optimize your chances of securing the airway, you incur an absolute, non-negotiable, ethical and clinical responsibility to ensure adequate, deep, and continuous post-intubation sedation.
You cannot just secure the tube, high-five the respiratory therapist, and walk away to a computer to write your procedure note.
No. You have to actively manage the powerful pharmacology you just unleashed into that patient's bloodstream.
It's an ongoing process.
Okay, Taking all of this complex information in, the observational stats, the receptor biology, the reality of the 100 milligram vial, your risks of awake paralysis, let's bring it right down to the bedside where it matters. I am going to ask you the ultimate clinical question verbatim. If I am intubating someone in the ICU tonight, does this change what I do?
I will answer you as cautiously and precisely as the data demands. Not necessarily.
Not necessarily. That is the classic, frustrating, beautifully nuanced medical answer.
It is the only honest answer we can give based on observational data. This study absolutely does not prove that every single patient in your ICU tonight should automatically receive more than 1.2 milligrams per kilogram of rocuronium.
You cannot look at this retrospective data and declare the FDA label is wrong, everyone needs 2 vials.
Because the dose of rocuronium is just one single ingredient in a very complex multi-step recipe for success.
Exactly. First-pass intubation success is never a function of just the paralytic dose alone. It is the end result of the entire airway management bundle being executed flawlessly.
Right. Let's explicitly list out the components of that bundle, because they all matter just as much, if not more, than the exact milligram dose of the paralytic.
You need optimal patient positioning, getting the ear to the sternal notch, ramping them up meticulously if they are obese to align the airway axis.
You need flawless, aggressive preoxygenation, utilizing flush rate oxygen or non-invasive ventilation to fill their functional residual capacity with as much oxygen as possible to buy you safe apnea time before they desaturate.
You have to carefully choose the right induction medication at the exact right dose, tailored for their specific hemodynamic profile.
You should absolutely be using video laryngoscopy if it's available and you're trained on it, as the DEVICE trial so clearly demonstrated.
You need a proactive strategy for bougie or stylet use.
You need operator experience. The person holding the blade needs to know exactly what anatomy they are looking at and how to manipulate the airway dynamically.
And you need patience and timing. You have to actually wait long enough for the paralytic to circulate and do its job at the receptors before you start prying the patient's mouth open.
However, to conclude this deep dive into the literature, what the study does provide is a very compelling, biologically plausible argument that underdosing rocuronium may be a modifiable contributor to suboptimal intubating conditions in the critically ill.
A modifiable contributor. I like that phrasing. It is something we actually have control over in the chaos.
If you are doing everything else in the bundle perfectly, the positioning is great, the preoxygenation is maximized, the equipment is ready, but you are still consistently struggling to get a clean view and a relaxed, compliant airway, this study gives you a very reasonable, evidence-based foundation
to selectively consider whether your standard dose of paralytic was actually sufficient for that specific, highly deranged, critically ill phenotype.
Exactly. It suggests that in the right hands, for the right carefully selected patient, reaching for a slightly higher dose is a biologically plausible strategy to optimize your conditions.
But, and this is the vital final caveat, this concept absolutely demands rigorous confirmation in a prospective randomized controlled trial before it can ever be adopted as the standard of care.
It's the ultimate clinical cliffhanger. We desperately need the randomized trial to give us the final answer.
All right, we have covered a massive amount of physiological and statistical ground today, navigating from the microscopic nicotinic receptors at the neuromuscular junction, through complex propensity matching models, all the way to the terrifying bedside reality of awake paralysis.
Let's synthesize this entire deep dive into 3 definitive, bedside-ready takeaway points for everyone listening.
Point number 1. In this very large secondary observational analysis of trial data, rocuronium doses above 1.2 milligrams per kilogram were significantly associated with higher first-attempt intubation success rates.
Point number 2. This association was not a universal truth across all hospital environments. The strongest signal by far was isolated to ICU patients, where the higher dose was associated with a massive 10 percentage point absolute difference in success, translating to a very compelling number needed to treat of about 10.
And point number 3, the crucial, unavoidable caveat. This is observational evidence. It is not definitive proof of causality. It is a powerful, thought-provoking hypothesis that absolutely requires validation in a randomized trial to account for all those unmeasured variables and clinical biases we discussed.
Which brings us to our final overarching philosophy for this entire complex topic.
I will let you deliver it.
The goal is not simply to give more paralytic. The goal is to create the best possible conditions for a safe first attempt.
That is the perfect, patient-centered summary. You are treating the complex physiology of the patient in front of you, not just blindly pushing a drug based on a math equation.
Exactly.
And here's a final thought to mull over. As we talk about the flaws of the eyeball test and the cognitive load of doing math in a crisis, I wonder how long it will be until we aren't choosing the dose at all.
What do you mean?
Well, imagine a near future where machine learning algorithms continuously analyzing the patient's real-time physiologic data streams, their cardiac output, their volume of distribution, their inflammatory markers, instantly calculate and recommend the exact personalized dose of paralytic required for that specific patient at that specific second, removing the 100 milligram vial bias entirely.
It is a wild thought, but given the data we just reviewed, perhaps a necessary evolution.
Thank you so much for joining us for this deep dive. If you found this in-depth discussion valuable, please like, follow, or subscribe on Apple Podcasts, Spotify, or wherever you listen to your audio. And most importantly, share this deep dive with a colleague. Start a debate on your next shift. Ask them what they think about the 100 milligram vial phenomenon and whether they are dosing the patient or just dosing the vial.
These exact conversations, questioning our ingrained habits, are how clinical practice truly evolves.
Educational use only. This is not medical advice. We will see you on the next one.
Thanks for spending your time with PRISM Rounds. If this episode was useful, please like, follow, or subscribe, and share it with a colleague. Leave a comment with your bedside takeaway, a question, or a paper you'd like covered next. Your feedback helps shape future episodes. Thanks again for listening. Educational use only, not medical advice.